So you've got the physicians that are leaving employed models, moving into independent models, financial upside, what the value prop of this model is, and if there's any sort of pushback from the hospital side, how you've mitigated that.
I don't view us as competitive to hospitals. So we have built very symbiotic relationships with those hospitals for the doctors that we've extracted. Extraction doesn't mean that they are off on an island and never need the hospital. Patients are going to need to be in the hospital. And to have a great practice, you're going to need a great hospital partner for when your patient needs a hospital to go there. Our big thing is we provide care at the appropriate site that it needs to be done at. Something can be done in an ambulatory environment. We should do it in an ambulatory environment. Patients shouldn't be forced to do it in a hospital environment at a hospital cost for the same tests, same procedures, same outcome. So there is a way to have a co-management arrangement where you're working together, but you don't have this like, I must own everything. Not every hospital is prepared for that conversation. Not every hospital CEO can wrap their brain around it.
Welcome to the Analyzing Healthcare podcast brought to you by Scale Community. Scale is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events to interactive peer networking opportunities and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
All right, welcome to the next episode of Analyzing Healthcare by Scale Community. I am pleased to be joined by co-founder and CEO of CardioOne, Jasen Gundersen, longtime friend as well. But Jason, welcome to the podcast. Excited to have you here.
Yeah, thanks for having me. It's great to be here.
So maybe why don't we just start with a quick intro to CardioOne, where you focus and what the organization is, and then lots to dissect in this conversation that we're excited to go into detail on, which we can do from there.
Sure. So CardioOne, we are a practice enablement platform built specifically to enable and support independent cardiologists. Always a little interesting when people hear that because we're non-acquisition, we don't own, we're not buying, but we're really trying to help cardiologists live, thrive, and survive in an independent practice. It's a little bit kind of like, going back to where we all started. And so we built the platform and it's a full support platform. I like to tell people we do everything but pay doctors and NPs and PAs. We'll support the practice through all the other services that they can need.
I'm excited to dive into the details on all that you just mentioned. I think, non-acquisition, supporting independent cardiologists, all exciting topics that we'll cover. Maybe before we do that, just a quick overview of the cardiology landscape or an update on the cardiology landscape. What are you seeing in the broader market that has you excited? Maybe that has you nervous? What are the key trends that are of focus as you look at across the national cardio map?
Sure. I mean, I think cardiology in general is an interesting specialty because if you look back 20-ish years, like when I first graduated residency, a little over 20 years now, most of cardiology was independent, something about maybe 15-ish% of the docs were employed. And you fast forward to today, and that number is about 85% employed and about 10-15% are still in independent practices. And that rapid consolidation and verticalization of cardiology, just everybody buying them and rolling them up, has not really been good for cardiologists, patients, and the overall healthcare system. We've moved a lot of testing and work into kind of vertical hospital systems where, hospital outpatient departments, high dollar costs are kind of located. So I would call, it's 5-6 years ago, I think things started to get interesting. And a lot of that came from Medicare allowing angioplasties or PCI, but, in English, like angioplasties and angiograms to be done in an ambulatory surgical center. And that was kind of the first trigger for some of the interest and investment in cardiology because people started to see an opportunity for cardiologists to own in ASCs and to start to shift some of those testing and procedures from a hospital into that ambulatory outpatient department. That's picked up speed this past year as electrophysiology procedures have come on. And so you had a real fast rise, 5-6 years ago, in some of the PE, more kind of acquisitory roll-up models that were started popping up. And they really grabbed the remaining big independent groups that were out there. But as I kind of mentioned before, there's there's not a ton of those left. And so what you're seeing now is like the big independent groups, there's really not many left for like an acquisition standpoint. But there is still an interest in this migration to ambulatory surgical centers. So if I saw it right now, I think some of the kind of big acquisitions and from some of the other cardiology groups have slowed. We're certainly not seeing the numbers of announcements that we had before. We still see a significant interest in ambulatory surgical center development. We can have an offline conversation around the federal versus the state regulations that have made that a challenge. But what we have seen is a significant interest in cardiologists regaining or reclaiming their independence. And so what we're seeing is cardiologists looking and saying, hey, I got swept up in this, get bought by a health system employment, and they're not happy. The health systems are going around saying, hey, it costs too much. We can't afford it. Schedules are being changed. So they don't have that autonomy that they really wanted. And so we've seen a big rise in people interested in kind of going back to being independent again. So we have nicknamed it extractions, where we take employed physicians and take them out of a health system or a big employed environment, like we did an Optum group as well, and set them up in their own practice. And they're interested in that for two ways. One, I think the hospital physician relationship is really strained and they're very unhappy. And then two, they're very excited about the opportunity for investment in ASC, imaging centers, ambulatory monitoring, like how they can really kind of like craft their practice. And so the summary of it is, I think we've rolled up practices way too fast. People are frustrated. And now we're looking at other kind of venues to have physicians kind of go back to being independent. And, I think it's a great thing because we do way too many tests and procedures in a hospital environment that should be done in an ambulatory environment. Or the hospitals love that hospital outpatient department billing where it looks like an ambulatory practice, but you get a crazy bill. Like I got a bill for a $5,200 echocardiogram in Colorado because they snuck me into a hospital outpatient department, which doesn't make sense. So I know I said a lot. We can review and touch on a bunch of those, but it's a passionate area for us.
Lots of tailwinds to the outpatient market with growing regulatory approval of procedures migrating from the hospital to the outpatient ambulatory market. Do you have a sense, like, if, call it 5-6 years ago when that started to open up, we were at, 85% hospital employment in the cardiology market. Do you have a sense for where we are today? Have those numbers started to come down as they're dent, or is it still dominated by the hospital employment model?
Still dominated by the hospital employment model for two reasons. One, they have absolutely insane control over the payer market in terms of demanding significant payment rates, which have then just resulted in pretty high payment per RVU that they're paying the cardiologists. So they have unbelievable control over the commercial payer market where they're just, I'm kind of sarcastic. They really hold the payers hostage because they control so much of it. And then two, the ambulatory surgical center environment is really a significant opportunity. However, the hospital lobbying environment has done a really good job at the state level of blocking cardiology procedures in ambulatory surgical center. So unlike orthopedics or GI, which have really migrated a substantial number of procedures right out into ambulatory surgical center, we were just talking about my shoulder surgery, done it in a great ASC, in and out, super efficient. Historically, cardiology, back when we started doing cardiac caths, was, when I was a resident and early in my career, you couldn't do those without being in a hospital without open heart surgery. So a lot of the states have managed to lobby at the state level to prevent those. So you can cover them. Medicare covers PCI and ablations, but lots of states block it. And so that is the second challenge.
So said differently, if the hospitals employ, call it 85, maybe it's 80%, maybe it's 75%, but the large majority of cardiologists, does that mean that these private equity backed roll-ups in the cardiology market are really consolidating only that minority share of the market that was not?
Yeah, if you look at it, they're really consolidating it really is a minority share. Everyone talks it like there's a lot of bad press around PE in healthcare or even like PE in cardiology, but we represent a very small subset of the environment. Most cardiologists are employed by health systems, and most of the health systems are not-for-profits, if you just look at it. So that's where the majority of them are. Some markets have a little bit more kind of independent remaining, but it's incredibly rolled up into health systems.
And the other sort of topic that's come up, and again, cardiovascular sort of expanding the scope of what's included in the market, but there are lots of tailwinds that are driving, procedures from hospitals into the outpatient environment. There are a few areas where there have been some reimbursement cuts, things that have been procedures that have been done in OBLs where there were rated higher. Are there any headwinds that you're seeing in the market, or is it all pretty favorable expanding outpatient market that you're approaching?
The only one that I would say that I think has some potential headwinds is the cardiac PET space. Significant opportunity for better, more precise cardiac stress testing using cardiac PET testing versus the regular nuclear testing. There is some pressure at the federal level to try to reduce reimbursement there, similar to what happened with the SPEC or the original nuclear testing. That could be one. There's actually, I can talk about it because we've just put it together. It just got rolled out. All the cardiology groups, we've gotten a big group together and formed the Cardiac PET Coalition, and people can look at it. And that's really a group of docs trying to work because we really want this testing to be available to patients. Right now, it's pretty much done in hospitals, but we can do it in an ambulatory environment at a much lower cost. It's much better testing in terms of sensitivity, specificity for patients. So that's the one that we're working on. I mean, we're always fighting the Medicare physician fee schedule. So there's PET was this very specific one. The payer market in general, we always talk about the Medicare physician fee schedule. Physicians keep getting cut. Private doctors get obliterated by that because they're not rolled into the hospital side. And then the commercial payer environment is not friendly to independent docs of any sort. We talk to them about it, but they're just so focused on the health system. So I think there's reimbursement challenges that we'll always be working through. We like to say site neutrality. I think everyone talks about it. I don't know if anyone will ever get it done, but that's a significant tailwind that I think people are starting to figure out we need to do something around. So we balance those as we go forward.
Yeah.
The ASC is probably the frustrating headwind for us. We have great groups ready to go, and then there's these arcane, very difficult state regulations that are blocking them for no medical reason.
So just protecting the hospitals. It's
there's a doc I know that I'd have to ask him if I could talk about it, but he's done a ton of research in ambulatory, EP procedures in ASC, just as safe as a hospital. There's no reason to not allow them, but the states, there are clearly states around the country that just have rules around them, like they have to be done on hospital property or something.
So let's talk about CardioOne. I mean, you mentioned this extraction model. So your peers maybe are going after more M&A strategies. I'm aware that some larger groups are going after clinically integrated networks as a non-M&A strategy, but it sounds like you're doing something different, really focused on extractions or taking hospital employed physicians and moving them into independent practice. So walk us through that process. How many of these have you done? How do they come about? What's involved to essentially open up a new practice with these hospitals?
So it first hit our radar about a little over 2 years ago when our first group calls up and they're like, hey, they're really frustrated. Hospital ownership was changing, just kind of everything was falling apart, and they wanted to go out on their own. But a lot of docs really struggle with how do you do that, from real estate to contracting to equipment to hiring staff and the rest. And so we worked with a group up in New Hampshire, Cardiovascular Specialists of New England. They were our first extraction. It was 9 physicians and 3 advanced practice clinicians, and we took them private. It'll be 2 years in September. They've since added a 10th doc and a 4th APC. They're now 2 sites. They have in-office PET, intensive cardiac rehab, echo, you name it. I mean, they're doing everything. Incredibly successful. And then we've just, that led to our second group, Cardio Now in Washington, our third group, which just started in just outside of Chicago. And I would say pretty much our entire pipeline are extractions of some variety of doctors calling us. I would say that it takes a lot of work to take a group and move them from an employed model into a fully independent model. One other group, there's, of companies in the CV space, Heart and Vascular Partners did an extraction in Colorado Springs. A little different because they kind of moved them. It's a slightly different model because they're doing more of the private equity ownership model. But the docs that come to us are very specific. Like, they do not want anybody to own in their group. They want that autonomy, independence, but they don't know how to do it. And so we do everything from real estate, site selection. We will actually do full builds. So we took an empty shell in Seattle and built out a complete office with a PET-CT, CTA imaging suite and an OBL all associated with it. So we'll do everything. They'll basically sign up with us. And the difference being they have their own kind of company with the doctors in it. We're a partner to them. And then we'll do real estate build out. We'll do the logo design, website build, hire all the staff, all the contracts, equipment procurement, set it up and run it. And so been super exciting to do. The docs that have done it couldn't be happier. They have retained the autonomy. They've learned how to drive the business the way that they've wanted to drive the business, like the services that they wanted to provide, the schedules that they wanted to do it. And so that model continues to ramp. The extractions are, I would call it a longer tent pole when we do them. So it takes from the time we talk to a group to the time that they're extracted can take 2 years, depending on how organized they are, real estate, the rest. But it's usually a longer conversation because it's a big step to leave an employed model and move out.
So let's talk about the sort of the value prop to each of the stakeholders. So you've got the physicians that are leaving employed models, moving into independent models, financial upside. There's maybe more risk to counter that. You've got, CardioOne, and then you've got the hospital. So talk us through from each of these stakeholder perspectives, what the value prop of this model is, and if there's any sort of pushback from the hospital side, how you've mitigated that.
Yeah. So I would talk about one we always skip. From a patient standpoint, I think the value is tremendous because we are now using true ambulatory code. So people aren't getting these insane bills for hospital-based procedures, and everything is in our practices is in the office. And that sounds like an obvious thing, but I met a group of 10, I think it was 10 cardiologists in New Jersey that did not have a treadmill to do stress tests in their office, and they did not have an ultrasound to do echocardiograms in the office. Patients had to go somewhere else. That's absurd.
Cheaper and more convenient. Not a bad.
Yeah, I mean, it's like, why would you do that? So the physicians love it because they've gotten back to, that true autonomy. They decide what services they want to provide, what schedules they want to do. They own that business in a way that they didn't before. Like they control it. And the excitement that you see working with them, it's infectious. We all love it because they're so excited about the business, how they're working it. They work really hard at access. You can pretty much see any one of our CardioOne docs with probably 2 days notice. It's not like you call a generalized number and you wait 3 months for an appointment. So just that ownership side of it is huge. Now, obviously they've taken on risk, right? There's no guarantees in this. There's not, they have to work with the payors we work with the payors to get rates. So there is risk to it, but they've all seen the opportunity to build and grow that business, to fundamentally own it, to build equity and value in the practice. Right now, the docs get paid a good comp per RVU, but when they leave, they got the 401k and they're gone. When they own their own business, they actually see the value of that. And so significant value to patients, significant value to the docs. The docs are trading risk, right? Because you got to make sure the hospital's cooperating. There's no salary guarantee, right? So if we've had to work with them if you take 3 weeks off, there's going to be a dip in comp. And so we've tried to, our job is to mitigate that as much as possible by bringing in the business expertise, the contracting, the efficiencies, economies of scale, revenue cycle, and really managing that for them. So we mitigate as much of the downside risk as possible. And we've made a replicatable model. Hospitals. Let's talk about hospitals. I don't view us as competitive to hospitals. Now, hospitals may think I'm completely insane, but I think this whole idea, so one, when you tell a hospital, they all have an immediate allergic reaction stroke over this whole idea of not employing and controlling the doctors, which I think is the fundamental flaw in all of this is it doesn't need to be that way. So we have built very symbiotic relationships with those hospitals for the doctors that we've extracted. Extraction doesn't mean that they are off on an island and never need the hospital. Patients are going to need to be in the hospital. And to have a great practice, you're going to need a great hospital partner for when your patient needs a hospital to go there. Our big thing is we should provide care at the appropriate site that it needs to be done at. So if something can be done in an ambulatory environment, we should do it in an ambulatory environment. Patients shouldn't be forced to do it in a hospital environment at a hospital cost for the same tests, same procedures, same outcome. And so I think when you think about putting the right test at the right place at the right time, there's really not an argument for the hospital. We should be doing that. And so we've set up co-management relationships and very close relationships with the hospital to, we still provide coverage. We provide heart attack. Sometimes I use technical terms, but like STEMI coverage for heart attacks. We just still do procedures in the hospital. They manage heart failure clinics. And so we have a very strong relationship with those hospitals. And so there is a way to have a co-management arrangement where you're working together, but you don't have this like, I must own everything. Not every hospital is prepared for that conversation. Not every hospital CEO can wrap their brain around it, but we've done a really good job with it. I mean, we were working with a group outside of Chicago that has an extraordinarily strong relationship with the hospital, and the hospital loves it. So I think when people start to see it work, right now there is like everybody does the same model. I go out, I buy, I employ all my like every health system does the same thing. I employ every specialty I can. We end up with like I live outside of Denver. God, there must be like 9 systems here, and they're all employing every doctor that they can find. So there is a way to do it. I think that as we go forward, that clock is going to unwind because buying and employing all those doctors has driven costs up, and the hospitals are frankly not good at working the physician practice side. And, you know, every hospital's like, I'm losing money on all my physicians. So we can find ways to do that.
Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire lifecycle. Denial Shield is an AI solution that proactively prevents and automates the resolution of denials, stopping revenue leakage before claims are even submitted. Front Desk Shield supports preclinical, administrative, and front-end RCM functions, incorporating eligibility, prior authorization agents to eliminate friction early in the patient journey. Revenue Shield maximizes revenue by automating coding, charge capture, and revenue integrity functions, ensuring accurate and complete reimbursement. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scale-healthcare.com and see how the Shield suite is redefining AI-powered RCM.
Have you gone through any de novo ASC builds at your extractions?
In the process of one right now, battling the state regulatory challenges. And then we've built a couple of OBLs for practices where ASCs are more challenged.
And is the ASC potentially a bridge from this outpatient market to the hospital? So, you know, for example, minority hospital ownership in an ASC, or you really look to keep the ASC separate?
No, I think we would be more than happy to partner with a hospital in one. I went to a meeting with a hospital that wanted to do one, and they brought their lawyer to the kind of get together dinner meeting. And I mean, majority control, all the board control, 50 mile non-compete. I mean, it was like, yes, there's a great way to do them, but hospitals don't, I'm beating up on hospitals, but they get this command and control concept. Absolutely interested in working with a hospital on one. I think the hospitals need to think about true partnerships. We've become this command and control thing.
Yeah, so, I mean, I was going to say, and you sort of beat me to it, but hospitals often complain about the complexity, the challenge with managing a physician network. So, you know, notwithstanding that I think hospitals also view cardiology as oftentimes strategic to their portfolio, the idea that you have a partner who can bring these physicians independent, maybe you retain some financial connectivity through an ASC and have happy physicians, better managed practices, you would think would be, you know, a positive for these hospitals if you can find the right balance.
Yeah, I mean, that's why I've always said we're not competitive. I mean, I think part of our issue in general in healthcare is this, that we have the zero-sum competition, right? In order for me to win, I have to take market share from you. But nobody ever says like, hey, if we both figure out the system, we have better access for patients and people get in and get care. And right, there's a backlog of people, like try to get a cardiology appointment anywhere. Anybody that's listening, call up the local health system and be like, hey, I need a new appointment to see a cardiologist. You're going to wait. Like, we've not solved the problem. So I do like, that's where I think, you know, just in general, I mean, other specialties have led the way more on this. You know, orthopedics definitely has a lot more ambulatory surgical center development and more independent ortho kind of partnerships with hospitals. Same thing with GI. Cardiology, I think, is headed in that direction.
Yeah.
We just need to find a way. There seems to be, you know, everything swings back and forth. We went through this rapid hospital has to buy everybody.
Yeah.
And now with site neutrality lingering out there, we all know that they're really struggling with the models that they're running. I think people are starting to look at like, maybe we shouldn't do this the way we're doing it. And so I think we're trying to offer that bridge that says, one, you can't just send all the doctors out into the wild. I trained a little while ago. Like, we don't really get business training and how to run a business. So you kind of like go to medical school, you do residency, and then people wonder why docs struggled with like the practice side of it. We're trying to take that administrative burden from them so that they can focus on the clinical side.
Yeah, I mean, lots of MSOs are looking for ways to diversify away from heavy CapEx, M&A driven growth. So I mentioned clinically integrated networks. We see that across a number of groups. So let's, from that perspective of thinking about extractions as an alternative, an organic growth model, maybe sort of zoom out and evaluate it as a business model. So first question I have is, how predictable are these extractions? I mean, you're taking physicians who are culturally used to being employed. Their referral streams are somewhat embedded. They have an ancillary service ecosystem that drives their economics and allows the hospitals to pay their compensation at a certain level. You're getting rid of all that and needing to rebuild it. You don't have a physical office. That needs to be rebuilt too. So when you look back to your original models that have projected out, this is what we think we can do with our extractions, and you compare that versus where you've landed. How predictable and how accurate are those models?
We're early-ish stages of it, but we're pretty predictable in how we can do the model. We've learned that there are certain things that we need to do to make sure that those are successful in the model. So maybe that's a better way I could answer it. So one, that we need to have a strong physician group with strong physician governance. The groups that have been able to move through and get to an extraction and execute on one have really strong kind of governance leadership structure of the physician side. They can make decisions, execute, follow through. So that's critical. Two, it's about seeing people in the office. So if you have a heavy procedural group of docs that just want to be in the lab all the time, someone needs to be in the office, because the office visits drive ancillary revenue streams, which are really how you kind of migrate off this hospital side, move to the ambulatory side. It's good for revenue. It's better for patients. So you have to have strong governance, a strong focus on building the core of the practice, which is really seeing patients in the office. And then you have to have ancillary revenue streams. You cannot just go into this and say, I'm just going to survive on just seeing patients alone. There's not unfortunately, the way that our kind of physician fee schedule is, without ancillary testing to go along with the office visit, there's usually not enough revenue to kind of keep that afloat. And so those are big components that we work through. So right group, right kind of office visit structure and mindset. And then we have a very strong budgeting process as it relates to how much office space, what kind of office space, building the office, like all those components that go into it. We have lots of very realistic conversations with the docs around building this site from the ground up is going to cost you millions of dollars and how it works. And so we do a lot of work around how that will come together so that it becomes an economically viable practice. And then our job is to mitigate as much downside risk on that.
And is CardioOne participating in the capital deployment to build the new sites and the ancillary services, or that's all underwritten by the physicians that are leaving?
It's largely all done by the physician side due to limitations on how our governmental regulations around physicians and comp and stuff. There's a lot of limitations. You can't loan money to doctors and the rest. We will invest capital as a minority into an ambulatory surgical center. That is because that's a separate and unique entity from the physician group side. That's one area where we'll put capital.
So the next question in sort of in evaluating the business model would be, what's the ROI, or the whole goal was to create a growth strategy that is lower capital intensive requirements. And it sounds like you've succeeded in that. I mean, it sounds like a fairly low capital intensive effort, especially if a lot of the capital is being contributed from the physicians on their side. So is that correct? Anything to add in terms of that?
We do all the implementation. We don't charge on the implementation fee. So all the work that goes into it, we cover. So there's an investment on that. Our biggest investment is people, talent, and systems. So we have a fully built tech stack, everything that a physician needs, from single suite, EMR, integrated rev cycle, all the way through to setup with PACS, virtual care, imaging. So there's a lot of investment we've made so that, if a physician group tried to do it on their own, they'd have to build all that. So we can deploy tech fast. We have resources and teams, recruitment, people that do website builds and marketing, logo development. Like, there's a lot of work that we've invested on that side. Scalability is important to us. It does open up a significant addressable market. And we really think, one of the big areas that it opens up as payers start to think about this and patients start to see it, there's a significant need for non-hospital based physicians, testing, and work. We cannot afford to have everything hospital based. It doesn't. It's not good for patients. It's not good for the system. So as we start to build these ecosystems of physicians that come out, have their extractions, very appealing to payers, ambulatory surgical centers, again, shifting. And we're not saying everything belongs in an ambulatory environment, but things like an echo should, in my view, if you're an ambulatory, I consider myself an athlete, even though I'm not the youngest person out there. Like an echo for me, like for a healthy person, for a checkup, I don't need a hospital-based echo. Like, anyway, it's a soapbox that I get very upset about. But
Yeah,
so I think as the market is really like opens the addressable market because there's not as many independents left. There is an interest. I mean, payers have come to us looking for alternatives than the high cost components. And I think as patients start to figure out that they can call directly into the practice, talk to the front desk, get seen right away, have their tests there, it becomes much more appealing, I think. And I think there's a big drive towards that as we go forward.
So we talked about the predictability. We talked about, the return on investment from the CardioOne side. What about the growth? I mean, you mentioned the TAM and the addressable market has expanded, but it sounds like you're looking for a particular type of situation where, they have the right culture amongst these physicians that are looking to be entrepreneurs. So out of that, call it 80+% that's employed by hospitals, do you have a view of what percentage would be suitable for an extraction model?
I think, that number is going to grow. So one, everyone's been brainwashed. I mean, not brainwashed, sorry, my sarcasm. Everyone's just kind of like, the docs are like, well, I show up, how much per RVU? Like, that's all they know. As physicians start to see other physicians, like when we tell people, like whether we're at MedAxiom or, ACC about the extraction, some docs are like kind of stupefied by the whole idea. Like, you can actually, like, I don't think docs ever thought that there was an option to do it, right? Because to do it on your own was daunting. So I think that addressable market is going to get bigger and bigger as more docs come on board. And we have great examples to show them, because a lot of docs are anxious, like, what does it mean for me comp-wise? When they can call a couple of our practices and they say, yeah, this is how it works, this is what we make, that number will continue. That addressable market, I think, will continue to expand. So because it provides more opportunity. And then as payers get on board, so you get ambulatory surgical centers, regulatory problem solved, we could probably open 10 new practices tomorrow if I could get the regulatory component fixed. We actually have a waiting list of docs that are just like everything, like ready to go. Solve for that. And then some assurance from a payer that they're going to get a good contract for opens the door. So I think that addressable market goes up. What it could be, I actually think we were way over indexed on physicians being employed by health systems. Like, that number should probably be cut in half.
Do you see
every hospital would
applicability?
freak out.
Do you see applicability to this model outside of cardiology? And is that something CardioOne would ever explore? Or do you think that really the focus on a given specialty to understand all that goes into the extraction from that specialty's vantage point is key to the success?
One, we're sticking with cardiology because we think there's just so much runway there. One of the problems, I think, in general is you just start mixing specialties, you become just like a hospital. So a hospital treats their like, if you think about it, a hospital uses the same EMR and basically the same process for the cardiologist, the GI, the ortho, the primary, like, it's epic. You do it. And that's our systems. We build everything for cardiologists. So I think we're going to stick as CardioOne with cardiology. I think there's opportunity in other specialties. They're kind of already, I think, maybe there, like ortho. You need to have the opportunity to move. It really fundamentally, in my view, you have to have a site of care solution. If you can't shift high dollar procedure testing from a hospital-based environment to an ambulatory environment in that specialty, it's hard to justify it. So, like, think about those specialties that have procedures that could be done in ambulatory, ASC type environments. You got like ophthalmology, they kind of already there. Ortho, GI, like all the scopes, like, are all done in ambulatory surgical centers. Like, they're not doing it in hospitals anymore. You look at the remaining specialties, there's not a ton left. Like, pulmonary doesn't really have any procedures or testing, or ID, like, there's just not as many there. It would be great if we could shift some out, but I think the site of care opportunity for movement to like keep the comp the same, drive the needle on the payer side is just, I've thought about it a lot. I don't know if there's another specialty that's like a big target.
Yep. When you look at these different alternatives in the market, hospital employment, it sounds like you think is over-indexed, in the aggregate. I'm curious about, how you'd rank other alternatives. So there's extraction, there's clinically integrated networks, which is a different version of staying independent. There's MSO acquisition. what do you expect over the next 3 to 5 years that we're going to see? Do we keep the ratios the same? Does extraction become the dominant popular model in cardiology? What are your thoughts?
Well, a couple of thoughts on that. So I think extractions are an opportunity, whether the more acquisitory companies can do extractions. That's the challenge right now. Like, it's really hard to be like, all right, I work for the hospital, I get a great comp per RVU, and then I go out into this model where you give me some money, but then if there's a scrape, and you own part of it, did I really just leave Intermountain Health to go work for Advent Health? What's the difference? So I don't know that there's as much runway there. I do think the acquisitory models are challenged right now, just due to the general, even the PE and healthcare in general is just challenged from a federal and state regulatory environment. So how they continue to grow, I think some of them will have to come together to do that. I hope we stop this just insane hospital employment model. I just think that it's bad for us all. Clinically integrated networks are interesting. I think one of the challenges there is how do you get consistency from an operations tech leverage, the running of the practice. There's giving somebody a rate, and then there's just running the practice. And when we say run the practice, a lot of people think about rev cycle, which is a huge component. We have our own recruitment hiring team for office staff. And a lot of docs are like, oh. I'm like, listen, if you don't have an ultrasound tech, you can't do echoes, right? If you don't have a medical assistant, there's no one to bring your patients back. So how we support those folks, I think our model in a SIN, we could start doing a lot of work together to kind of aggregate.
Yeah, it sounds like maybe they're complementary. And I think
I think
one of the differences, as I'm just kind of thinking about this versus the SIN, is you're starting from scratch. So you have the opportunity to, without owning, create a level of standardization, I think, across your network. So you mentioned sort of tech stack, standardized. I would imagine there's a fair amount of operational consistency across your network because you're starting from scratch. Is that fair?
Yeah. I mean, even we still work with docs that are independent and roll over. So everybody goes on, we call it Rhythm. That's our tech platform. So everyone's on single tech stack. So we have we've built a data warehouse for all those practices. So we run enhanced reporting, and we have efficiencies because we have packs fully integrated. And it's from a doc standpoint, it's much more efficient. It's all fully built, all customized. And then for payers, or even when we've talked to SINs, we can deploy that across all the practices, and we handle all the tech deployment so that all those practices are on single platform. I mean, I think one of the global problems in U.S. healthcare, not to get on my soapbox again, is we have all these EMRs and we have this total myth BS of interoperability. Nothing talks to itself. If we were all on one integrated thing, when it all shared, it would be a whole lot more efficient. We can actually bring that, if you meet a CardioOne practice, we don't tell them how to clinically practice. They do whatever they want, and they can tweak the platform, but they're all when you need to plug in and get data, we can get it to one site. So I think they are complementary. We've talked to some SINs and some folks in the payer space looking to do that, where they're trying to get aggregated and get some consistency. Not to say that they have to tell doctors how to practice, but even just no one wants to run 20 integrations. Right?
Yeah, it's a different skill set to manage this, truly independent network versus to manage an owned network. So yeah, I think the skill set, whether you're building from scratch or not, could be very relevant to another group that has maybe an owned presence, but also clinically integrated network service lines of their business. Interesting. Well, Jason, I want to thank you so much for taking the time to share a little bit about how you've approached your growth model. And it is quite different than what we see with many organizations. So kudos to you and the CardioOne team for building out something that sounds like it's a great value to the patients and the providers, and also a creative way to create a non-M&A driven growth strategy. So thanks so much for the time.
Thanks, Jason. Great being here.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.